Impact of Expert Center Endoscopic Assessment of Confirmed Low-Grade Dysplasia in Barrett's Esophagus Diagnosed in Community Hospitals. Introduction. Barrett's esophagus is the most important risk factor for development of esophageal adenocarcinoma. The malignant degeneration occurs through a stepwise process of phenotypic cellular changes from non-dysplastic Barrett's esophagus intestinal metaplasia to low-grade dysplasia, high-grade dysplasia, and eventually esophageal adenocarcinoma. In advanced stages, esophageal adenocarcinoma is a disease with a poor prognosis. Adequate surveillance strategies for patients with Barrett's esophagus are therefore essential to detect neoplasia at an early stage when it is amenable to curative endoscopic treatment. The strongest predictor of progression to high-grade dysplasia and esophageal adenocarcinoma in Barrett's esophagus is a diagnosis of low-grade dysplasia confirmed by an expert pathologist. The histological diagnosis of low-grade dysplasia is challenging because the distinction between dysplastic changes and reactive atypia of reflux-induced inflammation is difficult. 2 prior studies demonstrated that low-grade dysplasia diagnosed by a community pathologist was downgraded to non-dysplastic Barrett's esophagus in 73% to 85% after review by a Barrett's esophagus expert pathologist. After downstaging to non-dysplastic Barrett's esophagus, the risk of progression to high-grade dysplasia and esophageal adenocarcinoma was less than 1% per patient year. In contrast, for confirmed low-grade dysplasia, the risk of malignant progression increased to 9% to 13% per patient year. Therefore, current guidelines advise that a community diagnosis of low-grade dysplasia is reviewed and, if necessary, revised by an experienced pathologist. In the Netherlands, Barrett's esophagus treatment is centralized. While Barrett's esophagus surveillance endoscopies are performed in community hospitals, endoscopic treatment is restricted to 9 Barrett Expert Centers. Patients with visible lesions, high-grade dysplasia, and/or cancer are directly referred to a Barrett Expert Center for endoscopic treatment. Since 2017, the Dutch guideline has recommended that patients with confirmed low-grade dysplasia are also referred to an expert center for a dedicated restaging endoscopy. This is based on the idea that low-grade dysplasia is a predictor for progression to high-grade dysplasia or cancer, and that patients may benefit from dedicated restaging endoscopies with the option for early intervention if there are visible lesions. Furthermore, several trials have demonstrated significant risk reduction of progression from low-grade dysplasia to high-grade dysplasia and esophageal adenocarcinoma after radiofrequency ablation of the Barrett's esophagus when compared with surveillance alone. Most guidelines, therefore, state that prophylactic ablation should be considered for Barrett's esophagus with repetitive diagnoses of low-grade dysplasia. In the current study, the authors evaluated the diagnostic value of restaging endoscopy performed in an expert center for patients with confirmed low-grade dysplasia. Methods. This retrospective cohort study included all patients with flat Barrett's esophagus diagnosed in a community hospital who had confirmed low-grade dysplasia and were referred to one of the 9 Barrett Expert Centers in the Netherlands. The primary outcome was the proportion of patients with prevalent high-grade dysplasia or cancer during restaging in a Barrett Expert Center. Results. Of the 248 patients with confirmed low-grade dysplasia, restaging in the Barrett Expert Center revealed high-grade dysplasia or cancer in 23%. In 79%, high-grade dysplasia or cancer in a newly detected visible lesion was diagnosed. Of the remaining patients, restaging in the Barrett Expert Center showed a second diagnosis of confirmed low-grade dysplasia in 68%, while the remaining 9% had non-dysplastic Barrett's esophagus. Conclusion. 1/4 of patients with apparent flat Barrett's esophagus with confirmed low-grade dysplasia diagnosed in a community hospital had prevalent high-grade dysplasia or cancer after restaging at an expert center. This endorses the advice to refer patients with confirmed low-grade dysplasia, including in the absence of visible lesions, to an expert center for restaging endoscopy.